Good morning, everyone. So this is week 12. In week 12, we have three different chapters. We have intracranial pressure, we have brain injury, and we have spinal cord injury. I only have talked about the brain injury, so I'm not going to go in detail on that, but if I'll get a chance, I'll make one more video on that. Spinal cord injury, you already have the video, the D2L. So the only thing that leaves us in week 12 is the intracranial pressure. So let's talk about that. Before we talk about that, we have to start our topic with the brain and the different component of the brain. So our skull has three essential components, which is your brain tissue, blood, and cerebrospinal fluid. The easy way to remember is think of blood-brain barrier. Blood for intravascular blood, which consists of 12%, and then you have your cerebrospinal fluid, which consists of the 10%, that's your barrier, and your brain tissue, which is your brain, consists of 28%. Now, there are several factors that affect the intracranial pressure, such as arterial pressure, venous pressure, intra-abdominal, and intrathoracic pressure, posture, temperature, blood gas such as CO2. How exactly does they affect? So, if we have the increase in arterial blood pressure, it increases the cerebral blood volume, which in turn raises the intracranial pressure. Similarly, if there is a decrease in arterial pressure, it reduces the cerebral blood flow and lower the intracranial pressure. So with arterial pressure, if it increases, ICP increases. If it decreases, ICP decreases. With the venous pressure increase, such as from obstruction of the jugular vein, it can lead to have reduced venous drainage from the brain. So all the fluid is not draining back from the blood, causing us to have increased ICP. So even with the increase in venous pressure, you'll have increased ICP because all of the drainage is not getting out of the brain. With the increased abdominal or thoracic pressure, for example, if you have a full stomach, or you have constipation or mechanical ventilation, it can impede venous return from the brain, causing us to have increased intracranial pressure. Laying flat or head down position can also increase the venous pressure and increases the intracranial pressure. Whereas while sitting or elevating the head of the bed by 30 to 45 degrees, it promotes the better venous drainage and thereby lowering the intracranial pressure. So posture wise, you don't want to lay the patient flat or head down. If a patient is at the risk for having the increased intracranial pressure, you want to let them sit or elevate the head of the bed at least 30 to 45 degree angle. We can also have fever or elevated body temperature, which increases the brain metabolism, which causes us to have vasodilation, which increases the cerebral blood flow and still increases the intracranial pressure. So hypothermia can reduce the brain metabolism and lower the ICP, but hyperthermia or increased body temperature can cause us to have increased ICP. If you have elevated CO2, which is your hypercapnia state, which it causes to have cerebral vasodilation, which increases the cerebral blood volume, and subsequently it raises the intracranial pressure. Low CO2 causes the vasoconstriction and it lowers the ICP. So in general, if you have increased arterial pressure or venous pressure or intra-abdominal and intrathoracic pressure, or the posture is laying flat or head down, or if you have temperature which is hyperthermia, or if you have too much of the CO2, then it will raises the intracranial pressure. The only time your intracranial pressure will be decreased if when you have low carbon dioxide gas, you have hypothermia, and your posture of the patient is sitting or 30 to 45 degree angle of the bed. Those are the situations where you have decreased intracranial pressure. Now let's talk about the regulation and maintenance. So we have Monroe-Kellie Doctrine, which states that the skull is a closed system, so the volume has to stay proportional. She gave us the formula of volume intracranial equals to volume of brain plus volume of blood plus volume of cerebrospinal fluid. If one of the component increases, another must decrease because the ability to compensate is really limited. Our brain is covered by skull, which is cranium, and it's really hard, so there is not a lot of space where it can expand. On an average, our normal ICP is 5 to 15 mm of mercury, And ICP actually is the amount of pressure that is exerted by the volume from the brain tissue, blood, and the CSF. So all three which we see over here combined together, the pressure of all three is what we call the intracranial pressure. And the normal range is 5 to 15. So when we say that they have to be proportional, what we are saying that in normal condition, if there is an increase in volume, such as blood, brain tissue swelling, or CSF, the body will attempt to compensate that by adjusting the volume of the other two components. For example, let's say that there is an increase in the brain tissue due to the swelling. Now, to manage that, the cerebrospinal fluid must be displaced or absorbed to make more room. Okay. Similarly, if there is a blood volume increase, for example, due to the hemorrhage, then the venous blood may be compressed, reducing its volume and preventing an increase in intracranial pressure. But not always this works. There could be a possibility where there is a failure of compensation. However, if the compensation is limited, when these mechanisms fail, ICP begins to rise. And as we already said, skull is rigid. The brain is unable to expand, which lead us to have increased pressure within the skull. Now let's talk about something called cerebral blood flow, which just measures the blood in mils, which give us an idea that this is the volume of blood passing through 100 grams of brain tissue in 1 minute. On an average, 50 ml of blood travels through 100 grams of brain tissue per minute. They try to maintain the autoregulation. It adjusts the diameter of the blood vessels, which ensures the consistent cerebral blood flow. Cerebral blood flow is only effective if your MAP is 70 to 150 mm of mercury. Cerebral perfusion pressure is the pressure that drives the blood flow to the brain. So we can say that cerebral perfusion pressure is really, really important because that's the pressure that drives the blood flow to the brain, and we want to have the continuous blood flow to the brain because brain cannot survive without the blood. Even if we have interruption for only 4 minutes, it will start to die. Therefore, we have this formula to calculate CPP, which is your cerebral perfusion pressure, equals to MAP minus intracranial pressure, and the normal is 6 to 200. Easy way to remember, think of CPP as your heart rate, which is 6 to 200, but in this case it's mmF mercury. If you have less than a 50, it means that the brain is not getting enough blood flow. As a result, it will be associated with ischemia and neuronal death. Now we have a question over here. I didn't try to make it difficult, but this is something which require us to have the two calculation. So I'll try to see if I can use this screen and show you guys. It says a patient suffered a traumatic brain injury, has the following parameters. You have your MAP, which is 110, and your ICP is 18. MAP is 110, ICP is 18. We know that due to the changes in the patient condition, the MAP is expected to be increased by 15% in the next hour, and the ICP is expected to increase by 10%. Calculate the CPP now and after 1 hour. So CPP, we said cerebral perfusion pressure is MAP minus ICP. If you'll do MAP minus ICP, it will become 110 minus 18. Super simple, nothing to worry about. And you get 92, and the unit will be mmHg. Now, after 1 hour, the question says that our MAP, whatever it is right now, is supposed to increase by 15%. So it will be 15 by 100 times 110. So whatever it is, plus increase by 15% of that number, which will give us 126.5. Similarly, ICP is supposed to increase by 10%. So you have 18 plus 18 by 100 into your ICP is 18. 10%. It's supposed to increase by 10%. So 10 by 100 into 18, which will give us 19.8. So the new cerebral perfusion pressure equals to new MAP which is 126.5, minus new ICP, which is 19.8, which gives us answer, 106.7 mm of mercury. So we can say that it will increase from 92 mm of Hg to 106.7 mm of Hg. That's your cerebral perfusion pressure. And we just said cerebral perfusion pressure, normal range is 60 to 100. So that's not something to be expected. Okay, so now we have increased ICP. Okay, so now we have increased intracranial pressure. We just talked about this formula, CPP, which is your cerebral blood perfusion, equals MAP minus intracranial pressure. If you have your intracranial pressure elevated, which means increased, look at this relationship over here. If your ICP increases, it means that your negative number increases. If your negative number increases, your CPP, cerebral perfusion pressure, will decrease. So that's what this image is telling us. Your ICP elevation will cause reduced perfusion of the brain tissue. So our brain tissues are not getting enough perfusion, as well as initial trigger may be the reduction in arterial blood pressure. Both of them can cause us to have reduced perfusion to the brain. If there's a reduced perfusion to the brain tissue, body will try to compensate that. It will cause us to have cerebral vasodilation, mostly increasing the volume of blood in the venous compartment. It will try to do that, which will further increase your ICP. So it's in the circle, going back and forth, and back and forth. Okay. Then we have herniation. Herniation is a life-threatening medical condition that occurs when we have the brain tissue which is forced to shift from one part of the skull to another. Causes include traumatic brain injury, intracranial hemorrhage, brain tumors, hydrocephalus, infection, cerebral edema, and so on. When you have the traumatic brain injury, a head injury causes the swelling or bleeding in the brain, which causes herniation. With the increased intracranial hemorrhage, there is a bleeding in the brain, such as in the subdural or epidural hematoma. Talking about the epidural hematoma, something to know for the exam is epidural hematoma is when you have loose consciousness. When you lose your consciousness, you come back and then go back to the lucid state. That's what happens when you have the epidural hematoma. With the brain tumor, there is a mass that affects due to the tumor that causes the pressure on the surrounding brain tissue, causes us to have herniation. Hydrocephalus, abnormal accumulation of CSF in the ventricle of the brain, causing us to have increased pressure. Conditions such as meningitis or abscesses causes the swelling and pressure buildup in the brain. Lastly, cerebral edema is the brain swelling due to the metabolic or toxic condition, causes us to have the herniation again. Okay. What are the clinical manifestation? You will see the change in level of consciousness. That's the most sensitive and earliest indicator. You will also see the change in vital signs. Most importantly, you'll see the Cushing triad, and that's something I want you to pay attention to because that's kind of need to know. With the Cushing triad, you'll have increase in systole blood pressure, or in other words, there will be increase in pulse pressure. The difference between systole and diastole will be a lot. You'll have decrease in pulse, means decreased heart rate, increased blood pressure, decreased heart rate, and decreased respiration or abnormal. When we say abnormal, it could be such as Kussmaul respiration and so on. There will be the decrease in motor function. You'll see headache, which gets worse in the morning, and vomiting. Why? Because during nighttime we lay flat, there is a buildup of carbon dioxide gas, there is an increase in the intracranial pressure. The increase in intracranial pressure is making it worse in the morning, and you also have the vomiting is one of the other signs. Decorticate and decerebrate posturing is the indication of the intracranial pressure as well as the brain bleed as well as the stroke. So decorticates is when you have your hands coming towards your core. Decerebrate is when you have your hands getting outside of your core body. Both of them are really bad indication of the brain damage. Decerebrate is worse than the decorticates because decorticates indicates the initial brain bleed, whereas decerebrate includes the latter stage. Diagnostic wise, we do the CT scan, MRI, PET scan, EEG, cerebral angiography, ICP, and brain tissue oxygenation measurement. But what we don't do is no lumbar puncture, and that's something we need to know. So why do we we don't want to do the lumbar puncture. Okay. So when we have increase in the intracranial pressure, the pressure within the skull is elevated. Performing a lumbar puncture, what it will do, it will cause a sudden pressure imbalance between the intracranial pressure, which is in the skull, and the spinal canal. The rapid removal of the CSF from the lumbar region during a lumbar puncture can create a pressure gradient, which may cause the brain to shift and herniate through the opening in the skull, which we call the foramen ovale. Foramen magnum. This shift of brain tissue, such as the herniation, which we just talked about, can lead us to have severe neurological damage, or even in some cases death, by compressing the brainstem, which controls the vital functions such as respiration and heart rate. That's why we don't want to do the lumbar puncture. In simple terms, if we do the lumbar puncture, the increased intracranial pressure in the brain and the decreased pressure in the spinal cord region will get mismatched, and it will try to balance that and try to balance it really, really fast, which will cause us to have the herniation of the vital organ of the brain, which controls the vital functions such as respiration and heart rate. As a result, it could be lethal. How do you want to measure the intracranial pressure? There are several guidelines, indication, but one of the standard way to do it is your invasive, which is the intravascular catheter. That's the gold standard, where you just place the tube in the brain ventricles, and that provides the accurate reading and also allows us to have the CSF drainage. Intravascular catheter. You also have non-invasive process such as placing of the subdural, epidural catheter. The other includes MRI CT scan that help us to identify the elevation of the ICP, but it does not measure the pressure directly. So the best way is to measure is your invasive procedure, which is intravascular catheter, and we call it ventriculostomy. And like the name says, ostomy means drainage. We literally surgically make a small hole in the ventricles of the brain to allow the drainage of those cerebrospinal fluid. This is usually done to relieve the increased intracranial pressure. Could there be any complication? Yes. We can have infection, bleeding, catheter issue, over drainage of the fluid, hydrocephalus, and so on. The one thing we need to be careful as a nurse is the leveling of the transducer. Okay, and we'll talk about the leveling of the transducer. So number one, we want to make sure that it is in the correct positioning. It should be always at the level of the head, or in the book it says external auditory meatus or meatus, your EAM or foramen of Monroe as the reference point. So always at your ear range. You want to level it clearly with the patient information, room number, name, and so on. You want to make sure that the transducer is properly calibrated, either manually or automatically, and document the calibration. You want to make sure it's the sterile procedure. This is not something which you give it to the LPN or your tech. After any patient movement, you have to check the level again and make sure that it is in the correct position. You also have to do the documentation of any changes in the transducer position, calibration, ICP increase or decrease, and any of the proper management. Those are the things we need to be careful with the leveling of the transducer. Now let's talk about the nursing care. We have to treat the underlying cause. Our goal is to decrease ICP and support as much of a brain function as possible. If you have a GCS of 15, what are your intervention gonna be? And if you have a GCS of 3, what are your intervention gonna be? If a patient is having headache all of a sudden or first thing in the morning, or if they have a change in level of consciousness, you have to monitor those things. You have to monitor the vital signs, especially the Cushing triad, which is your increased heart rate, increased blood pressure, decreased heart rate, change in respiration sign. You also have to make sure to manage your respiratory system, where you have to make sure the head of the bed is 30 to 45 degree angle. Suction always has to be there. Minimum abdominal distension. Monitor ABG continuously. Intubation and mechanical ventilation if needed. Other things to be mindful about is the cardiac. Make sure that there is a we have to be mindful about the adequate cardiac output, monitor the fluids and electrolytes, because if there is a damage to the brain, it can cause us to have other things such as the diabetes insipidus or syndrome of inappropriate antidiuretic hormone if it causes us to have the damage to the posterior pituitary. We also want to make sure to have increased supply of glucose. We have to manage the pain and anxiety as well as the protect from the self-injury. Those kind of patients with the brain bleed can cause them to have the seizure as well. So you have to make sure that they're on the seizure precaution and not in a place where they will cause a lot of harm to themselves. Intervention to minimize the ICP and increase the cerebral blood flow. Head of blood 30 degree. Prevent extreme neck flexion. We don't want to do the extreme neck flexion at that point because it will increase the ICP and decrease the CPP. If a patient is trying to turn them slowly. Avoid coughing, straining, extreme hip movement. Limit the suctioning and agitating procedure. If a visitor are there, we need to educate them. Now, what are the drug therapy we can do? With the drug therapy, we want to give them anticonvulsant because they are the risk for having the seizures, such as phenytoin. Sedative, analgesics because they could be in a lot of pain. Corticosteroids to decrease the cerebral edema. They are the steroids. It will decrease the swelling. Osmotic diuretics such as mannitol. That's the gold standard, mannitol. It will increases the intravascular pressure by drawing the fluid from the interstitial space and from the brain, and will get rid from the body. And that's what we have in the intracranial pressure. Now let's just walk through some of the questions related to NCLEX. I hope you guys can see this, but it says question number 1. A nurse is caring for a patient who has sustained a traumatic brain injury and is at the risk for increased ICP. Which of the following actions should the nurse take to prevent an increase in ICP? I'll let you read. Position the patient with the head of the bed flat. Don't want to do that. Perform frequent gentle suctioning to clear the airway. Don't want to do that. It will irritate furthermore. Administer sedative and pain medication as prescribed. Yes, you want to do that. Encourage the patient to cough and deep breathe every hour. Nope, don't want to do that. Question number 2. So the answer to the question number 1 is option C. Administer the sedative and pain meds as prescribed. Okay. Then you have question number 2. A patient with a severe head injury is undergoing monitoring for increased intracranial pressure. The nurse noticed a sudden increase in ICP. Which of the following actions should the nurse make first? This one is easy and all of you can get it. Option B, elevate the head of the bed to 30 degrees because that's non-invasive, something you can do it by yourself, does not require any order. So you want to do that first. Question number 3. A nurse is caring for a patient with the increased ICP who have extended ventricular drainage in place. Which of the following nursing action is the most important when managing the EVD, your external ventricular drain? I'll let you read the options. Ensure the EVD is kept below the level of the patient head at all time. You don't want to do that at the level of the head. Position the EVD to the level of the EAM, external auditory metas, to maintain the accurate reading. Yes, we talked about this. We want it to be the level of the ear. So it will be the option number B. Question number 4. A nurse is caring for a patient with the external ventricular drain in place for monitoring the ICP. The nurse notes that the drain is cloudy. What is the nurse's most appropriate first action? Increase the drainage rate to decrease the ICP. Notify the healthcare provider about a possible infection. Flush the EVD with sterile saline. Change the dressing on the EVD side. And our answer will be notify the provider for the possible infection because a cloudy appearance indicates that it could be that there is an infection. Question number 5. A nurse is monitoring a patient with the increased ICP and notes that the patient's level of consciousness has deteriorated. Which of the following signs should the nurse interpret as a late sign of increased ICP? Restlessness and confusion. Increased systolic blood pressure with widening pulse pressure. Decreased respiratory rate with irregular pattern. pupil constriction, and sluggish reaction to the light. So one of the late reaction of the increased ICP is your Cushing triad, which indicates the increased systolic blood pressure, widened pulse pressure, and bradycardia, and other signs such as restlessness or confusion occurs in the earlier phase of the process. Question number 6. A nurse is caring for a patient with the increased ICP who have ventriculostomy catheter in place. The nurse noticed that the ICP reading are fluctuating. What is the nurse priority action? We already talked about this. We said we always want to make sure that the level is at the level of the ear. So ensure the catheter is level with the patient external ear canal, external auditory meatus. Question number 7. A patient with a brain injury is at the risk for increased intracranial pressure. Which of the following intervention would the nurse use to prevent an increase in ICP during suctioning? We said we don't need to suction because it will increase the ICP, but if we have to do the suction, then we want to apply suction for no longer than 15 seconds at a time. Because prolonged or frequent suctioning can increase the ICP. To minimize the risk, suctioning should be limited to with 10 to 15 seconds at a time to reduce the potential ICP spike. Okay? Hyperventilation, routing suctioning, and positioning the patient in Trendelenburg are not recommended. Why? Because it will increase the ICP. And that's all I had for you guys in the ICP. If you have any question, please let me know. And we'll see you in another video. Thank you.